Welcome everyone to the Global Surgery Fundamentals webinar. This is the first webinar of some that will come within the next few months. The Global Surgery Fundamentals is the starting point. What we did is we did a little data analysis and we found out that there were some issues going on with some of the modifiers related to global surgery. But unless we start at the beginning, which is where some of the questions came in, we won't be able to move to those modifiers. So more to come on that. Keep watching for those. My name's Tom Ryan, and I will be your presenter today. I'm with Provider Outreach and Education. I'm joined today by Ashley. Again, from my team, Ashley's going to place some links in the chat. She's going to monitor things and do a variety of different things going on there. So we want to make sure you're able to do that. You will be given the opportunity to provide some feedback, and that's via a survey. So I really would encourage you to take that survey. One of the things to please include on the survey is if there is a modifier that's causing you issues, something like that related to global surgery. Again, as we're building through, it was just too much to do in one webinar on an overall basis, which is why we started with the fundamentals. Then we'll move through a variety of modifiers, and we're going to kind of break those out a little bit. So again, keep watching for more to come on those. I do want to remind everyone that we do have a disclaimer because we do use CPT codes. So you will want to make sure that you are looking at the end of the PowerPoint presentation for the disclaimer if you're interested. But remember, we don't write them. And so that is something that you'll need to be aware of. Also, this information is for educational purposes only. It does change, meaning Medicare does change. So the information may or may not be current tomorrow. It was current this morning when I looked everything up and tried to re-verify everything. All right, let's get started with what we're actually covering in today's webinar on global surgery fundamentals. First, it is to get the basic understanding of what global surgery is and where you find information. Again, keep in mind, this is a basic webinar. Our starting point for those of you that were asking about global surgery and really just going back to the fundamentals, some of those really basic questions. So to do that, we will define global surgery. What does it mean to you? What does it mean to Medicare, and how is it used? We will then explain the global surgery period, the different periods that are used, and the days. Last, what we're going to do is show where to find those relative value files. Now these files, the RVU, relative value unit files, are available on the CMS website, but if you don't know how to read them and what's within them, you won't be able to use them. And that's a really fundamental and key starting point for Medicare when it comes to global surgery. So let's get started with some basic stuff. And the first thing we want to do is answer some questions. We did receive several questions. A couple of examples are, does global surgery apply to me? How do I know what global surgery is? So in order to answer those questions, I want to start back with the basic definition. And I kind of talked about this. We want to make sure that we're answering, getting started. I don't want to leave anyone behind. So global surgery package. You're going to hear global surgery and global surgery package used interchangeably for me. The global surgery package is a single fee paid to a surgeon for items that are normally included in the procedure. This is a pre, intra, and post-operative portion. Sometimes it's separately paid, sometimes it's not part of because of a different diagnosis or a different reason. And we'll talk more about some of those different situations, but that's also where you're going to find a series of webinars coming up on some of the modifier uses. Okay. Remember, global surgery applies to one provider billing a certain procedure code. That provider is the surgeon who did the service. They're paid for all of these unless you designate something different. And there are ways to designate that you're only doing the surgery and then you're transferring a portion or all of the global package, the post work, to another physician. So we'll talk more about that. Someone did refer to this as a bundling package, and yes, it is a bundled package based on a surgical code. Now, does it always have to be a surgery? No, there are other types of procedures that are within that. And so we'll talk more about that. So when we look at this, the pre-operative visit, this is the decision to operate. For most major surgeries, this includes the day before or the day of surgery. For a minor procedure, this is the day of surgery. So only thing included. And we'll talk more about the major and minor and how you locate those in just a little while. The intraoperative services, these are the usual and normal parts of a surgical procedure. They are routinely furnished with the surgical procedure, so they're part of the global surgery package. When CMS looks at the relative value units and looks at the formula to create the fee for the surgery, these are the items that are looked at within the work section of it. And so there's a dollar amount, or I'm sorry, it's not a dollar amount, it's a formula which assigns a portion of the dollar amount to the work factor. And that's what we're talking about. It's in the calculation for the fee schedule. You know, some of these would be like an injection of local anesthetic by the surgeon or opening and closing of a surgical site. You have to do that in order to do the surgery. If you're not opening and closing a surgical site, there's nothing to do. It would be different than general anesthetic versus local anesthetic. Remind you about that. So yes, you could call this a bundled package. It's one payment for everything that would normally happen during a surgical. The last part of it is the post-operative period. The post-operative period begins the day after the surgical procedure. So it's not the day of surgery, but it technically begins the day after. It includes follow-up visits related to the recovery from the surgery. If a surgery is done in an inpatient setting, it includes the visits by the surgeon during the hospital stay. It also includes post-surgical pain management by the surgeon. Complications following surgery are included unless they require a return trip to the operating room. That's more of one of the modifier items, so it may not be really worked into this one as much as you guys would like. So just so everyone is aware. So when we look at a global surgery package, it is a form of bundling in which the surgeon is paid for all necessary services. So if it's not medically necessary and the surgeon is performing it for whatever reason, that is not a payable service. The reason that I put that in starts this one, and we'll talk a little bit about that. So if someone asked us about the preoperative visits, they have a process in place that says they must visit the primary care for a preoperative decision for every patient. Well, the question is, why? What makes it medically necessary that you have to visit that that primary care doctor for that preoperative visit? And that's a medical necessity evaluation and management question because that's typically what they're billing. But the other deciding factor with that is when we look at the service, when we look at the surgical service, there is a portion that is called the preoperative visit, and that should be your built-in section. So why is that being done by someone else other than the surgeon? You know, the surgeon is a trained medical doctor or doctor of osteopathy, so why aren't they doing that portion? Now, again, if you say, well, there's these 5 complications and this person has this, that, 2 totally different situations. Maybe you're sending them to a cardiovascular consultation, or I'm sorry, cardiovascular decision because they have heart problems. Well, that's a different type of situation, and that can make it separately payable. So the preoperative visit is the decision to do the operation, and then also can incorporate the day of the event or the day before the event, depending. And what it's looking for is, are they safe to do it today? I was asked specifically, someone has a surgeon who did a preoperative visit and determined that the patient was sick, like sick, so they couldn't do that. That is still billable. It's a preoperative procedure code. So yeah, you could bill for that. Again, it was a discontinued procedure, and what portion of that discontinued procedure are you incorporating? We'll talk more about determining the actual payment level for that when we get into the relative value units file. There's a little bit more to come on that. Again, intraoperative, this incorporates anything the surgeon does during. It's not necessarily if it's a complex or a larger procedure, it's not necessarily the anesthesiologist. That could be a separate type of situation and they could bill differently. So post-operative, we talked about this, but we want to make sure that they're medically necessary. You can't just go for post-operative care. Now, the reason that I put that in there is someone said we also have a situation where we have care needed for what they termed as a minor procedure with a 10-day post-operative period. Okay, but our surgeon wants to see them more often than what is normal. Why? I'm not saying they shouldn't, and I'm not saying it's not incorporated. I just don't know what the reason is. Do they have a complicating disease, illness, or injury? Uh, you have to give us more than that in the question. So there's one that if you do have more to offer me, please put that in the chat. I don't really know where to go with that one. So I'm just going to ask you to do it that way. All right. Oop, sorry. There is some miscellaneous services that are incorporated into that medical necessity section. So I thought I would just kind of incorporate them. One, dressing changes would be considered a miscellaneous, right? You're not going back for another surgical procedure. You're not doing any of that, but you do want to keep it clean. Suture and staple removals are technically considered a miscellaneous service, however, are still part of the global package. And then bedside minor procedures. So depending on what's going on and where the patient is at, any of these could be considered. These are just examples. They do have a variety of different items that occur. Someone said what could be an example of a bedside minor procedure? How about the removal of a tube? So the drainage tube for a surgery, if the patient happens to be, in a situation where they need that done, could be done in an office as well. So when we say bedside, I'm not talking about a hospital bed. I'm just saying, hey, where's the patient at? That could be considered a minor procedure. And those are what we talk about when we talk about bedside minor procedures. Okay. All right. One of the big concepts for this is one provider. Now, what that means to Medicare is that it's a physician in the same group practice, in the same specialty, and they must be reimbursed as one single physician. So if a surgeon acts on behalf of another surgeon for follow-up, that's still the same surgeon. On the other hand, for a global concept, while one provider does apply, it is also a form of bundling. Remember, we talked about that. So this does come into play. When we look at it, we say, okay, for sure, definitely a same physician is going to work. You're going to get one code. The bundling portion says, well, what if it's done by someone outside of that group or someone outside of that specialty? Well, then what it does is it looks at what is being billed. So same procedure, same type of information, and says, hold on. Then we're going to apply it this way because this physician, whoever that is, could be the surgeon, was paid to do all portions of it, the pre, post, and intraoperative care. That's what the code includes. Now, don't get me wrong. There are codes that you could, or I'm sorry, modifiers that you can append to say, yeah, I'm not doing the post-operative care, and then this is going to be who it goes to. That's a different situation, and I don't want to get too hung up on that just yet. So when we look at one provider, we're really looking at one surgeon in this case. The reason that that came up and was asked about, and the question was, they have two separate surgeons working on different parts of the body at the same time. And by parts of the body, from the example, it was defined as a bilateral. They were working, one was working on the right hip and one was working on the left hip at the same time. Well, okay, so is it a bilateral procedure? By definition, what are we doing with it? Should we be billing it with RT-LT to signify separate? But it really would be billed by one physician. It's one surgical session. And so then we want to make sure we combine that. So hopefully that answers the question that you asked me. If not, please put some more information back in chat, okay? Along with that, they did ask if there were certain settings that this applies to and certain settings where it doesn't apply to. Yeah, it really does apply to the ambulatory surgery centers. Again, if a procedure is done in an ambulatory surgery center and has a global period, yes. Any form of a hospital, inpatient or outpatient. The question and the reason this was put in there is they said, does this apply to critical access hospitals? The answer is yes, it's still a global concept. Critical access hospitals is a payment method. Essentially, they have to meet some criteria and stuff like that. But yes, global surgery would apply should a surgery be done at a critical access hospital. Intensive care or critical care units, absolutely, and a physician's office. So we really want to make sure that we're getting all of those basics done when we look at that. There really isn't a setting where surgical code is billed that it wouldn't apply to. I don't know what that setting would be. So please make sure that you are aware of that. What's excluded? Well, excluded for a major surgery, which again, we'll define that what that is in just a few moments, but it's a 090 on the relative value file, which we haven't looked at yet, is excluded. The decision to do that is excluded. Now, it can be done more than 1 day before the surgery. In that case, you're still going to bill it. You're still going to bill it as whatever you want to do with it. And I say that because I'm not sure where you were, what setting you were in. I'm not sure which E&M code you're going to put on that. I don't know any of that. I don't have that information in front of me. So for an elective surgery, which could be a major surgery, but it's not something that needs to be done today. It's not something that's an emergent surgery. They're going to elect to do it. That decision could have been made days ago. And so then what comes in and doing the preoperative period is, are they sick? Can the patient sustain it today? Do they have a medical condition which prohibits it today? Something like that. So yes, you could actually bill an E&M code to say, yeah, this is the decision. And then the surgical period preoperative is more an evaluation to make sure that the patient, is okay today. So the physician service is in a different group or different specialty within the same group. This is an excluded service, and we talked about that. The physician's service says, hey, we need this, but I'm going to refer you to the surgeon, and then you're going to see the surgeon later today. That's still separate. Typically not going to happen, but that was just an example. Also, if you come in and you're going into the ER, that service would still be billable, even if a decision was made and they called in a surgeon. Now, the surgeon, when they come in to evaluate the patient and decides, okay, yeah, this is, yep, you're right, we need to do surgery on this. There's a difference between the two. The ER doctor, their services are separately payable. Okay? Visits unrelated to the surgical diagnosis. This one is one that I wanted to address from a question that y'all sent in for me. The patient had surgery. It was a 000, which means no preoperative day before. It's just a minor surgery. They went home. They came back later that same day, and what happened during that 000 postoperative period was that they had cut themselves with a knife. And so it's a big gash on their arm, according to what the information is that I had within it. Treating that arm is not part of that same day global period. You may need to modify it to indicate that, but it also doesn't work that way. Diagnostic tests or procedures and clearly distinct surgical procedures during a postoperative period. So it may be something that has to be scheduled out. It may be something that, whatever the situation is, it's separate. Or maybe that you did a hip replacement, but now you're going in, to do a bone fracture, which has nothing to do with the hip replacement. It actually is in the arm. That would be something like that. Hopefully that does make sense. So these are excluded. They're not part of the package because they, don't meet with that definition of global surgery package. Someone did ask me a lot about this one, and it's the post-operative complication, which does require a trip to the operating room. So it's not just a complication. Maybe they have an infection, but maybe the infection has grown, and now they have to do a trip to clean out the infection and do more work with it. Yes, that is and can be a different payment. It's not a normal part of the package. Unrelated critical care services for seriously injured or burned patients. So the burned part in this case was the question. The patient was actually burned in a house fire because they had had surgery and couldn't get out. They were able to be rescued, but in being rescued, they sustained burns. Well, yeah, we still want you to get the critical care services for the burn, but it's not related to the surgery. Now, the fact that the surgery complicated it because you couldn't get up and get out, that still doesn't make it related. It's just a complication that actually happened to happen during the scenario that was given to me. Treatment for underlying conditions or added courses of treatment. So we still want you to be treated for your diabetes, even though you had surgery. But that underlying condition of diabetes may have to have a separate course of treatment added. It may mean the drugs need to be adjusted, administered, changed, all of the normal things that we go with that. It's not the same thing. That's what makes it separate. It's still a significant, separately identifiable service, not about that. Okay. Also, separate you have an organ transplant, that's one type of service, but then you're going to have immunosuppressive therapy. You're going to have that evaluated. That immunosuppressive therapy and the related work for that is separate from the transplant because it's what maintains the body during that time. So hopefully all of that makes sense. Um, you know, I do want to remind everyone that there are examples, that you would need modifier 24, 40, 24 or 25, also maybe 78. And that's what we're going to talk about more in some of the other distinct modifier sessions is when do you want to append those modifiers, okay? So for instance, you would add a 78 for a related procedure during the postoperative period. So you have a hemorrhage that occurs. It's related to the original surgery, but you have to go in and fix that hemorrhage. Now you're going to add a 78 onto that. Maybe you have something happening with the global period performed by the same physician or a physician in the same group practice with the same specialty. And so you're adding a 24 or a 25 to say, hey, this evaluation and management, this service is not the same as part of that global. So you may need to add those. Those are all kind of scenario driven that we're going to look at a little bit more in some of the other ones. I just wanted to definitely bring them up and then we'll answer questions if we need to. Okay. Someone did ask me a very specific question, and the example they gave me is they have a patient who is having a lung removal. That's the 32480. During that process, they go into cardiac arrest, in which a cardiologist is called in, and so now it becomes a multi-specialty. The do they get to bill both services? Well, yes, I'm not sure that the cardiologist was doing a lung removal or not. I'm not sure what that surgical procedure would require. But if you're calling someone in and it's not related to that, yeah, I understand that the surgery, the lung removal portion did cause complications and that's what caused the cardiac arrest, but the cardiac arrest still needs to be treated. So yes, you would want to consider that separately. Now they didn't give me the second code or anything, so I couldn't do the actual comparison matches and some of the different things that we'll look at later. Okay. Okay. So the next set of items that we're going to go to is we're actually going to look at the global surgery periods. We're going to look at where they're located and we're going to talk about what you're going to see on these files. So there's a lot of information to go through in this section, but before I get too far into it, I do want to just remind you that these are located on the CMS website. I'll walk you through the information, kind of explain it so you have an idea of what we're looking at. And then the next section, we're going to go to the CMS website. We're going to open the files and I'm going to show you some of the different things that go with it. Okay. We received one of the main questions we received related to this is, are the days that are listed, the days that I'm going to talk about, are they calendar days? And the answer is yes. I'm not sure what else they would be, maybe working days. I'm not sure where the person was going with that, but they are calendar days. And we'll talk more about that as we go through. Now, the other question is when I mentioned something like 000 or 0, it is post-operative days. It means that the package only is the day of surgery. Okay, so we'll talk more about that. So here's the first one. What you'll see as an assigned code on there is 3 zeros. Now on there is on the relative value file for the physician fee schedule, which is where these codes are paid at, okay? So it's a 0 postoperative period. Keep in mind, you can use this relative value file even for critical access hospitals, rural health clinics, other things like that, though it doesn't necessarily mean the payment methodology is exactly the same. It's just whether or not this code will incorporate that. So hopefully that makes sense. I was asked about that specifically. So a 000 represents that the only thing included is the day of surgery. So the preoperative and postoperative care must occur on the day of surgery to be included in the package. If it's any other day, you would bill it separately for whatever reason, and you could bill that with an evaluation and management code. You could bill that with whatever you need to do to say, hey, this isn't there. So really when you see 000, it means 1. What's the one day? It's the day of surgery. That's the one day that's incorporated, okay? And so what does this type of information apply to? Endoscopies. endoscopies. That's a big one right there. Also, it's also for things like nail debridement or contraceptive capsules, where you're placing something, you're doing something, but it's not a major thing. Um, I was asked about contraceptive capsules because they said, does Medicare actually cover that? Yes, we do. It has to be medically necessary, and you can go through the variety of information on that. The person does not have to be 65 to be on Medicare, and so I think that may be where the question was coming from. Um, so yeah, we'll cover it. I don't know. Usually it's a disabled person, someone under 65 who's having this done. So hopefully that answers the question. I'm not really sure where you were going with that or what you were asking me, except for that as an example. So here again, please remember that when you see 000 on the relative value file, which we'll look at in a few moments, it really means 1, the day of surgery. Okay. The next one is a 10 post-operative day period. The key thing is right there on the top, and it says post-operative days, because it means the visits the day of the procedure is generally not payable, but also 10 days following. Now, why do we say generally not payable? Remember when we talked about exceptions and things that could be done? What if the day of the procedure you decided to do the procedure and it was a separate E&M service because you didn't even know you were doing it? That would require a modifier to say this is separate. So that's why it's written in that manner, generally not payable. Your total global days is 11. That is the day of the procedure and 10 days following. There's what we call no preoperative period. In other words, days before the surgery. The preoperative period is actually contained in the hours before the surgery within the 24-hour period that makes up that day of surgery. So 11. So 000 equals 1, 010 equals 11. So what types of thing would have an 11? What could be an acne surgery? Some of the debridement procedures would have this, and some of the skin tag removals will have this. Now, again, because of the complications and the things that are going on with those two, some of them may be a 000, and other ones may be a bit more significant. It really just depends. The best way to determine this is to use a procedure code, and we'll show you why that's so important. All right, the last one is the post-operative period. Now, the post-operative period of 090 means the visit the day before the surgery. So there's 1 day. The day of surgery is included, there's 2 days. But 90 days following the day of surgery. So that's 90 additional days, which means 92 days. So you have 1, 11, and 92. That's how the periods work. Now, significant amounts or significant portion has to be within this 90-day period in order to make that work. Okay, so when does this apply? Again, major surgeries, and this just provides a list of a couple of them. I'm not really sure what else would be within that. We would have to look it up. Again, I always tell people when you're looking this up, what you want to do is grab your procedure code and let's start there. Now, as part of the global surgery package, remember that if it's more than the day before, even on a 90-day global period, it doesn't incorporate it. So if you're making the decision to do a surgery and you're making it 90 days before, 10 days before, 8 days before, 5 days before, is that part of the global package? No. Why not? It's not within the definition that CMS uses for the global surgery package. So it doesn't matter if they're in an inpatient, outpatient setting, none of that matters in terms of when you're doing it. It's the number of days before the surgery. Because remember, by definition, even something doing a major surgery is only the day before, the day of, and 90 days thereafter. Okay? Now, if the decision to perform the surgery is on the day of surgery and it is excluded, you can then bill a modifier 57. So you didn't even know you were going to do a major surgery and then you're going to do it. Let me give you an example on this one. Someone comes in complaining of abdomen pain. When you go in, you're doing the examination, some testing, and you find out they have appendicitis and the appendix needs to be removed before it bursts. Well, did you know that when they came in that morning, they were going to have a surgery that afternoon? No. So hopefully that makes sense to everyone. There's also modifier 25, which would be reported for significant and separately identifiable E&M. So they came in the morning, they were not feeling well. They, they went home, okay, were treated, they went home. Then they came back later because they fell and broke their hip. And guess what? They shattered the hip. So now you have to do a hip surgery to get everything back in order. That first E&M would still be significant and separately identifiable. You'd want to report that with a modifier 25. So hopefully all of that makes sense. And again, more to come on those modifiers. Those are just a couple of quick thrown in examples, hopefully to help you understand a little bit. There are some other days that are on the global surgery column in the relative value unit. Global surgery, YYY. This is a contractor priced code. And so what that means is the contractor looks at the code, but they also then price it and establish how many global days are incorporated with it. And it's based on the documentation normally. So we'll ask for documentation, we'll do this. There are some codes or some combinations that we already have established, and we just simply go back and say, oh, you did this, that means this. So, but it's really based on that. ZZZ is an add-on code. For those of you that are not familiar with that, hey, I'm doing this surgery, I've got this add-on code because of this complication. The add-on code itself doesn't have global days. The add-on code is based on whatever the primary code was that it was added onto, and that's all the ZZZ is indicating. Yes, we recognize this code, but it's not separately payable. If you just billed us for that code, we wouldn't pay it. So we need the original code, the primary code, and we're going to use whatever global days are attached to that primary code to determine the global days for the add-on code. You'll also see what's called XXX. Just simply means not a global surgery concept. So there are some procedures and things that happen that just simply are not global surgery context at all. Those ones, we don't even look at those. We wouldn't consider that. Those are programmed into our system. So the reason CMS is putting them onto this chart is just to tell you, hey, there's nothing programmed into the system to make this look like a global surgery. It's not even an applicable item. So hopefully that kind of helps you out there. All right, we are at the section where I want to stop for a minute, and I really do want to take you out and show you how to locate these files. Before I do that, I just want to remind everyone, if you see something blue and underlines, it is a link. If you open that PowerPoint, so you could download the PowerPoint, you can grab that from our live events page. These will get you what you need. It's on the CMS website, cms.gov. Again, follow the steps on the slide, it'll get you there. I went to Medicare. This is where we're at. We want payments. Sliding over, I like fee schedules, but you can use all fee for service providers. It takes you a little bit longer to get there. In fee schedules, again, I like it because the first link right there on the left is physician fee schedule. So that's where we want to go, real easy. And then the top or the very first link, and we haven't looked at this yet. I wasn't even really explaining this. This is just a fast lookup tool. The actual file that you need is way down on the bottom. It's second to last under the physician fee schedule. And this is your relative value file. Here's an example of what that looks like. Again, here's your quarterly updates. If for some reason there was a quarterly revision off time, because remember quarterly revisions January, April, July, and October, those are just your normal quarterly revisions. You may see something like this, which is an R revision in the meantime. The one that I actually pulled up for you all to see is this one. And just want to highlight again, here's the dates for it, right? Here's the dates that it becomes effective, and it stays in effect until the next one is in effect. And then it tells you when was it last updated. If I selected this link, that's what will open this file up for me. And you can see it's just a zip file because there's a lot of information. The file that we're going to look at is the Excel file is the actual edits. The PDF is just an explanation. And that's where I was at. So we'll go back up to the top of the PDF. So it just says, okay, this is what it is. Lots of stuff interesting. I'm not a mathematician and I'm not calculating this for you, but here's the actual formula. They take these RVUs times each other plus each other and do all this stuff with the conversion factor. All of that's on the other file, which we will use to look at the global days, okay? But then we scroll down, and again, there's just a lot of basic information until you flip into the other view. and you'll see it, okay, here's an explanation, but here's where you're going to find the data record, which does translate to what's on the Excel file, okay? And so then you're going to want to just read through. I just like to scroll down if I'm looking for global days, and you can do a Control F or an Edit Find and do that. This is where I get my basic information for global days and what that means. So if I don't know what it is, I got to understand what it is. This may be my starting point, and I may need to just have this. That's fine. So, okay, with that said, I'm going to go ahead and open up the Excel file. Now, I did this in advance because it doesn't always like to work very well. A couple of columns I want to point out. O is global days. Here's the X saying this is not a global period. There's no global period associated. All right, well, that makes sense for what if you read what they're actually giving it to you, right? Preoperative, intraoperative, and postoperative percentages paid based on the global days. So if it does have a global day here, you will see point amounts here. That's how much we're paid. And they are based on that work relative value unit and how much work it takes to do for each one of the periods. So each one may have a different percentage. Each one may have a different percentage within this. And, we'll take a look at that. One of the things that I can do one of two ways. One, if I'm just looking for global days in general, I can highlight O, hit Control F or Edit Find. I have 90 days set up right now. And if I hit it, it'll just bring me to the first 90 day and I can move through that 11450, right? But let's say that that's not really what I want to do. And I'm going to go back to the top. And I'm like, okay, what I really want to do is find my procedure code because this is going to be more common. And so I'm going to look for 11451. Again, very similar to the 450, but it'll automatically bring me to it. Then what I'm going to do is say, okay, I know that this is an active code. It's not a carrier priced. That's important because that's where we had the CCCs. If you remember correctly, I defined that for you, and the global days will have CCCs. Then what I do is come over and say, oh, it's got a 90. So this procedure code, when billed, has the day before, the day of the procedure, and 90 days following. Those are calendar days, which equals 92 days. Along with that, you get 10% of the money for pre-care, 71% for intraoperative, the day of the procedure, and 19% for postoperative. And there are modifiers that can be used to designate any of these portions. So when we look at this, this is just important for us to understand because otherwise we may not get the right percentages. So if you are a surgeon and you said, I'm only going to do this portion, right? And you're in, let's say, a 10-day global period. Okay, well, that means you'll be paid for these two. And then you can show us that it transferred out to another provider and they get paid this one. So hopefully all of that makes sense. Okay, that's how to read these again. So you've got your procedure code, which is the surgical code, whether or not it's active, carrier priced, etc. Then you've got to move all the way over, and you're going to come to N, and in column N you'll find column O, not N, sorry. You'll find the global days, and again you'll find those different designations should it be something completely different. Percentages are then in P, Q, and R, and this is based on that. Okay, so that's your global period, how it works, what you're looking for, and where to find it. Now, someone asked, is there an easier way to look this up rather than opening this big sheet? Yeah, what did we use for 11451? Okay, so this column, the 11451, which just was the example that I used, is also available to you in an easy lookup format, and that's what I had mentioned before. I'm just going to jump back a second here. And what happens is when I come to the fee schedule, the first item is the lookup tool or the overview. And I can select that, and then it explains all about it, and you can, read through all the different items. I'm just going to begin the search. What are we doing? Oops, sorry. Accept the CPT agreement. Otherwise, you won't be able to use it. But I can say, okay, I want to look at this one. What type of information are you looking for? And you can say whatever you want. A lot of times I just leave it open information, but you could do relative value units. I am looking for a single CPT code. Okay, and I don't really have a preference for modifiers on this particular one, so here we go. By doing that, it will search, and then if you scroll down, it's the same information we just went through. Okay. We scroll over and we see that, oops, nope, sorry, I don't want relative value units. We'll just do all, it'll be easier. So it'll look exactly like the same thing, and you can actually scroll around and see the global days, or you should be able to see it. I'm not seeing the global days come up. All modifiers, single CPT codes. So this one isn't working for me in the way that I wanted it to. It did work earlier today. I'm not sure what happened. So, but it'll kind of help you through the different columns and things like that. I do usually recommend, this is just an extraction. It's not the full item. So I always recommend that if you really want to go through and you're really looking for everything that you want, go ahead and use the major downloadable Excel file right here at the top as well. It'll help you out. So again, let's go back just for a second. And I really do recommend that Excel file. Okay. Let's jump back to the PowerPoint. So we located it, we looked it up, we looked at the lookup tool, we did all those different things. One thing that to keep in mind is sometimes CMS has updates on their website on Thursday. A lot of times they do. Didn't think about that. So it means that this might be getting updated right now too. So just as a factor to consider, if you get something weird, you get a weird message, as we know that they do that, you know. Let me verify again. Ashley, can you see my PowerPoint again?
Yes, I can see your PowerPoint.
Okay. First, I'd like to do the pre-submitted questions, and we'll get through these. Not sure how many other questions we're going to get to, so we'll see how it goes. Global surgery periods only begin 24 hours. Many Advantage plans will not accept the existing explanation as it's very vague. They require a 79 modifier with the 90 days to previously surgical procedures and reimbursement claims. First, I want to focus in on some keywords here. Advantage plans. This equals Medicare Part C. Whether Medicare Part C, Medicare Advantage plans accept or use the global period, that's their item. Even if someone enters into a Medicare Advantage plan within 90 days after on a global, then you must follow their billing. So they may not use the global period the same. It may have a variety of different items going on with it. We don't know any of the Advantage plans, audits, and edits. We don't have that information available to us, which means that you do need to contact each plan to find out what their rules are, how they want something billed, etc., and whether or not they follow that global period. Question 2. At a postoperative follow-up visit, would a debridement be included in the global, or can we bill the debridement? The surgery has a 90-day global period. So here's where we kind of wind up with an interesting situation. What is the debridement related to? I'll give you an example. So the person has diabetes, they have a foot ulcer, which needs to be debrided, but the surgery was on their hip. Well, that would not be included in the postoperative period, right? It's very different things. On the other hand, the person has that and the debridement is on the hip. This could be included because it's something that needs to be done as part of the healing process related to the hip surgery. I'm going to kind of ask one of our clinicians who happens to be on if Mary Sue has any further input on that, because remember, it's really medically necessary, and they really have to look at the medical necessity for both. Also, whether or not the debridement is related to the surgery. So Mary Sue, do you have anything from a clinical perspective that I should be adding to that answer?
I don't, Tom. Thank you.
All right, thank you. So again, take a look at the documentation and really find out if the documentation supports it. Please remember that sometimes when you look at the documentation, you may have to ask for an addendum or additional information from the provider, and you need to make sure that gets documented as well. This is one of my favorite questions because it's not something we can answer at all. And is Medicare going to keep the global surgery packages? I don't know. This is a CMS call. CMS is providing indications of this. it's part of their claims processing. So though we enforce it, we use the systems to get through it. We build edits into the systems about it, and so do the system maintainers. I can't really tell you whether or not CMS is going to keep it going, what changes they're going to do with it. We don't know any more about that than you do until it happens, which can happen in the Code of Federal Regulations. It can happen in some of the different releases. So a variety of different methods can happen with that, but we don't really know what's going to happen with this global surgery package. Next question, when two surgeons work on one patient doing different parts, can this be modified? I don't know what different parts is. I don't know if they're related. I don't know if it isn't. Um, so this one's really hard. Like, what are they doing? What makes them different? Is it like an elbow and a knee? Is it a two hip thing? Is it a lung and a knee? There's so many questions that come up with this one for me. And so, yes, it could be modified if it's two completely separately different, if it's not written as a bilateral procedure and they're working on right and left. Things like that would all have to be considered before I can give you a definitive answer on this one. So really go back to the procedure code, help me understand, and look at what's going on. Okay. Also, does one portion need to be done for another portion? If you have to do this, then no, it's not a significant, it's part of the work for that period, that global package. All right, I'm going to keep going with the pre-submitted questions. I do have some that were pre-submitted, and I want to make sure that everyone gets their questions that pre-submitted. Again, this is why I said I may not get to some of these chat questions, but how does CMS calculate global payments? Again, the global payments are based on that percentage. So CMS uses the calculation, and I'm not going to even try to walk through this calculation. I've done it. It always kind of blows my mind a little bit. They use this calculation to get their base amount. Then what they do is they go into the system, no one actually manually calculates this, and they use these three fields depending on which portion you're doing. A lot of times what we do see is that this is its own separate item. And then this becomes a separately identifiable service because the surgeon actually transfers the care and indicates that on the claim. And if they do that, then this would be definitely payable separately, but they're only going to get 10% of the total fee. So if the fee is $100, they're only getting 10% of that fee, which is $10. Well, they would be getting $80 for the intraoperative care and $10 for the preoperative care. So what's going on with that? Who are you transferring what to? That's how CMS does calculate it. But they use all of these different percentages, put that into a pretty formula, and that spits out a dollar amount. Let's see. Does Medicare Advantage always follow the global package? Medicare Advantage plans can follow the global package, though it's not necessarily required. They have to have their own processing system, which is a correct statement. That global package may be included in their processing system. They also can do a variety of different things. So they may require you to modify a service and say, hey, I did the preoperative or the postoperative care on every claim. They may not allow for the quote unquote global package to be billed. It's not something we can answer, and it is advantage plan by advantage plan based because it's their system. So I don't have a solid answer for that other than to contact the individual advantage plans to see if they recognize that global package or do they recognize it as a service basis, how they're going to pay it essentially. Next question, if the patient comes in with a new problem of knee pain and the provider suspects arthritis, but does lab work and x-rays to look for the cause, diagnosis with arthritis, and decides to do a knee injection with steroids, does this meet the requirement of going above and beyond the procedure to charge for an additional E&M? Here's where I'm going to go with this. What was the initial procedure? Like, what happened? You know, if you're telling me they came in and they had a hip replacement and now they're saying I have knee pain and that's arthritis and the doctor is doing all that additional work, it's probably going to support it. Why do I say probably? I don't have your documentation in front of me. And, as Mary Sue will tell you, some of the stuff we get within the documentation, we have no idea what you're doing. So that's why we can't say it's automatically going to be supported. It does need to be properly documented, and it needs to show why it's different or not a complication of the original surgery, whatever the situation is. So we really do want to make sure your documentation is there to support that. So here's one, and then again, it's a bariatric surgery. It's an E&M encounter prior to the surgery, and it could be up to 10 to 13 days before. Is this considered part of the global period? First, when you're talking about bariatric surgeries, most of them have a 90-day global period. I say most because I didn't look up each procedure on a procedure-by-procedure basis. So, but most of them do have that 90-day period. Because of that, it is 1 day before and the day of surgery for our preoperative period, also followed 90 days thereafter. Is this within the 90-day, or is this within that preoperative period prior to the surgery? There's our answer. Now, following after, is it related? Do we know if it's related? What is the E&M for? What is the encounter for? What are you trying to evaluate? Because that may be included. But if it's not something related, then it would not be. And so I'm covering it from both aspects there. Okay. Could you clarify or give good examples of what Medicare considers a complication of surgery, such as a postoperative infection? Again, I'm going to give you some base information. I'm going to then see if Mary Sue has anything else to offer. Again, as the clinician, sometimes she gives a little bit more in there than I have. So here's some things that I understand are complications. One, is there bleeding going on? And that bleeding needs to be corrected. The site's not clotting correctly. Is there an infection? And that infection needs some type of to be addressed somehow. It might be a clean out of the infection, whatever the situation is. Are there blood clots related to that surgery? Is there nerve damage? And, basic wound healing. Is the wound healing properly? If not, what procedures are you doing to help with that wound healing? Those are complications. And so it's really dependent upon the surgery also, what goes with that surgery, what is part of that surgery. I'm gonna just stop for a second, and Mary Sue, anything that you can think of to add?
No, Tom, I think you gave some great examples of complications that could happen.
Okay, thank you. So please remember that you have to look at the surgery. If you don't look at the surgery, you won't be able to answer that question. So I just gave some base examples, but again, the surgery will derive that factor. Let's see. So if an EP provider sees a patient and states they want a cardioversion done the same day and a cardiologist does the cardioversion, can the EP bill for their visit on the same day as the cardioversion, since an EP provider did not do the cardioversion? Instead, a provider from a different specialty done. This is an example where you may have two different evaluation and management codes or two different procedures done on the same day. Not necessarily the same thing, but we do have to establish why this is being done. Just FYI for you. The next one, billing for services not provided by the surgeon. Not really sure what you mean by this, because that's the whole point of the global period. If it should be provided by the surgeon, because it is part of the package, it's going to incorporate within it, regardless of who does it. So let's talk about wound care, debridement, dressing removal, any of those. Those could all be part of the package. So I'm not really sure where to go with that one. But again, if it is something unrelated, you may need to build one of the modifiers, so attend the rest of the sessions coming up within the next few months. All right, I'm going to stop there because we are close to end of time, and I just want to give you guys a few wrap-up question things to be aware of. The next slide just gives you some resources. Please take a look at these. Lots of stuff going on with these resources, and I really want you to be able to have some basic things that you need. I will email you a certificate if you signed in with your email address. I don't actually do it. Our system does it. Doesn't have anything to do with me. The email should come shortly after this meeting ends. Oops, on the email, a couple of things to be aware of. One, there's going to be a link. The link is simply for the survey. So we're going to have Ashley put that in just a couple seconds in your chat, but there's some more information there. Two, the certificate of achievement will also be attached. It'll have today's date, contact hours. We don't issue contact or CEUs, a governing body does that. So whoever you need, whether it's AAPC, some other coding, some other entity, so they'll issue you based on our contact hours. Follow-up questions. If I did not get to your question and it is in the chat, what we will do is take the follow-up questions, combine those with questions submitted within the next 7 days. So questions in chat and the next 7 days, we'll combine those and send those in a response document. And the response document is just simply an email. It's not anything, complicated or anything like that. If you do come up within the next 7 days while I'm working on that document, feel free to email us and just include global surgery in the subject line just to help us out. And then we'll get that all together and send that back to you. I would like to encourage you to take this survey. I would really encourage you to take this survey and include in the comments, like if there's a specific modifier that I did or did not cover. I know I touched on quite a few just really briefly. So we're going to get into some more of those, but we want to make sure we get the questions and the information you need from those modifiers. So take the survey, provide us with the feedback. During that survey, you'll be able to rate today. You'll be able to rate overall WPS, and then again, rate me as a presenter in my PowerPoints. All right, that brings us to the end. So thank you for staying with me today. I want to remind you that the next slide after this one is simply the disclaimer slide. So take a look at those as you need to. We hope that you got some information out of it. We hope that you do take our survey and help us understand what you're looking for in the future. They do not, if you are adding a comment on what you want, it does not have to be related to the global surgery package. Please continue to review our lab events page for more information. On behalf of myself, Ashley, and all of Provider Outreach and Education, thank you for your participation. I do look forward to your survey comments. You may now disconnect.